So, good evening, all of you. I hope I'm audible and visible. Jiva, please give me a quick thumbs up if my audio video is fine. Ravi, uh, Jaya Lakshmi, Govind, Lokesh, Nikhilesh, Lega, Priya, please give me a quick thumbs up if my audio video is fine, all of you. Very nice, amazing. Welcome all of you in this series of high-yield MCQs. And today in this 10 p.m. session, we have Dermatology MCQ high-yield series. So I welcome all the students, Aditi, Vishnu, Sushmita, Dee, Sangita, Naveen, VS. Everybody is welcome in the class. I request all of you to please be live as early as possible. Chalo ji, amazing. So welcome Lavanya, Tushar, Dr. Tariq, Beneem, all of you, welcome in this session. So let's begin the today's class. So I think everybody knows me. I'm Dr. Chesta Agarwal, your NEET PG educator on Unacademy, and I've myself scored All India rank 261 in my entrance examination. Now I teach dermatology on the platform. On Unacademy, we have two type of subscriptions. One is Plus, which give you an access to live classes of Unacademy, and Iconic, which give you an access to both Unacademy and PrepLadder. PrepLadder has an added advantage of video lectures, question bank, rapid revision sessions, or clinical integrated essentials. Now, I think everybody is aware about this. Tomorrow at 11 a.m., we have a NEET PG scholarship or a combat test where the top 200 students will get scholarship. First three will get 100%, and then we have 75%, 50%, and 25% scholarship for 1 year NEET PG plus subscription. So I request all my dear students to please use my code CHESTA10 and get yourself enrolled into it. So please remember, it is tomorrow at 11 a.m. and a scholarship pool of 1 crore is there for all of you. Now the exam day for INI-CET is on 17th of October from 2 p.m. to 5 p.m. This is a free grand test for INI-CET. And for FMG, the test is on the same day, that is 17, but the timing is different from 10 a.m. to 1 p.m. So I request all these students to please be a part of this on 17th of October. Please use my code CHESTA10 to get yourself enrolled. And remember, this is absolutely free. You will not be charged for this. Okay. The next is we also have a lot of new questions on the platform. Around 25,000 plus questions has been uploaded on the platform. Okay. Now there are many new batches which I wanted to introduce here. That is the Target Next or an integrated batch 2023. Then we have a Target NEET PG batch for 2022. Both of them are starting on 13th of October. For the next 2023, it is a 2-year long batch, but for NEET PG, you have a 6-month batch. I request all of you to please take Unacademy subscription using the referral code so that you can get yourself enrolled. We also carry a clinical case-based batch, and the new batch will be starting on 13th. We have a feature where you can ask the doubt directly to your educator, and that is known as a raise a hand feature. I would recommend all of you to either take a shorter subscription of 3 month or 6 month for Plus if you are targeting 2021 exam, FMG or NEET PG. So NEET PG 2022, we are expecting it little early, maybe in March or Feb. So I think 6 month would be enough for that. And for Iconic also, I would recommend all of you to please take either 1 year subscription because it includes a lot of help. How raise a hand feature work? RP, if you click on raise a hand, you can record your voice, and when I click on this, I can hear your voice along with all the other students can hear your voice. So it's like direct one-to-one discussion. Instead of typing the whole question, you can clearly or easily ask your doubt by recording your voice. So that is ask a doubt feature. Chalo. So today we have a lot of high-yield question. It is a 60-minute session or a 1 hour session, starting with the first question of the today's session. And your time starts now. I hope you all can see the poll. Please give me a thumbs up if you all can see the poll. Okay, it is not visible. Let me check. Is it visible now? Yes, amazing, all of you, amazing. Very well done, Vaishnavi, Lega, Dr. Tariq, Ravi, Raj. Very well done, all my dear students. I can see a lot of old students as well in the today's session. Very well done. Raj, Rosh, Dr. Sana, Aruna, Shrishti, Lavanya, Monica, Tushar. Very well done. Now, what does the question says that a 60-year-old male patient presents with intensely pruritic rash on his palm. On examination, the erythroderma was accompanied. So, first very important point is erythroderma. Second point they tell in the question or they have given in the question is presence of lymphadenopathy. And the third point is atypical T cells which are present. Can you tell me what is this triad? What is this triad? Will it be late? Okay, so SWAT NEET PG 2020 2022, it can occur early in the next year, like it can be in March or it can be in April. We are not expecting much late exams because they want to regularize the like every year exams. They want to have a lot of students get enrolled by July. So I think that the next year exam, if there is no any other wave of COVID, I think it will be little early, but not in January. What I feel is it cannot be in January. It should be either in March or April. That is what is the prediction. Nothing is declared by the official authorities. Okay. Chalo. So this is a classical case of Sézary syndrome where you have a triad of erythroderma, atypical T cells, and lymphadenopathy. So option number one is absolutely right. Can arise de novo, it means that it can occur by itself without any preceding mycosis fungoides. This is also true. You can directly have Sézary syndrome without any preceding mycosis fungoides or the cutaneous phase. And third, it occurs because of leukemic dissemination of the mutated T cells. And please remember, it is already spread. It is already blood-borne, so it is not a slow spreading, it is a fast spreading malignancy. Understood, all of you? Please give me a thumbs up if you understood. And can you tell me which cutaneous malignancy is a slowly spreading cancer? Which malignancy is a slowly spreading cancer? Very nice, amazing. It is basal cell carcinoma. Absolutely right. It is basal cell carcinoma. The next question is on your screen. Little long question, and I request all of you to please read it carefully. Very nice, all of you. Chinmoy, absolutely right. Ravi, Lokesh, Dr. Tariq, amazing. Aruna, Rosh. A 10-year-old female presented with multiple brown lesions, which started on the face and further progressed to involve other part of the body, which includes trunk and extremities. Now, she gives a history of elevation and redness associated with twitching on the lesions, few minutes of rubbing. Can you tell me what does it mean? Any sign this describes? Any sign you know of? Yes, very nice. This is a classical Derrier sign. And please remember, Derrier sign is a feature of urticaria pigmentosa. Now, in the question, they have mentioned that there is no associated systemic symptom. It means that it is a pure cutaneous mastocytosis. It's a pure cutaneous mastocytosis. And can anybody tell me what is the gene defect in cutaneous mastocytosis or urticaria pigmentosa? Very nice, Ravi. It is the c-KIT mutation. It is the c-KIT mutation which is there or which is seen in the patients of urticaria pigmentosa. Clear? Now, can you tell me two more conditions which has Derrier sign positive other than urticaria pigmentosa? Anyone can tell me two more conditions where Derrier sign is positive. So please remember it is positive in xanthogranuloma. And anything, anything else other than urticaria pigmentosa, xanthogranuloma? Can you tell me any other condition? You have smooth muscle hematoma. But please remember, the Darius sign here is pseudo-Darius. It is pseudo-Darius in smooth muscle hematoma. Clear, all of you? So please remember, Darius sign can be seen in other conditions as well, but very classically demonstrated here with respect to urticaria pigmentosa. Yes, dimple sign is for dermatofibrosis, not angiofibroma, dermatofibrosis. Dimple sign is for dermatofibrosis, RP. Clear? Amazing. Can you all see the poll because it suddenly disappeared from my site? Can you see the poll? Okay. Can you see it now? Yes or no? Okay, very nice, very nice, very nice. Ravi, Raj, Aditya, can you see the poll now? Yes, okay, okay, okay. Okay. Now here, can you tell me what is the diagnosis? What are these velvety hyperpigmented skin lesions which are present in the intertriginous area? Anyone can tell me the diagnosis? Very nice, Ziva and Tushar. It is nothing but acanthosis nigricans. It is acanthosis nigricans. And please remember, all my dear students, acanthosis nigricans is of two types: benign variety and malignant variety. Benign variety and malignant variety. The benign variety is seen in young patient. So here it is 20-year-old female, and it is always or most of the time associated with metabolic syndromes, which includes PCOS. But the malignant variety is associated with old or elderly, and here you have gastric adenocarcinoma. It is gastric adenocarcinoma. Clear or not this question? Please give me a thumbs up if everybody have understood. This is very, very important for your exam. Very, very important for your exam. Very, very done, all of you. Clinically, can we differentiate whether it is benign or malignant? No, Sesha, it is same because it has nothing to do with malignancy. It is not that the malignant cells are going and infiltrating the skin. Acanthosis nigricans can be seen in both of them, okay? But you have to take the history of PCOS. If it is elderly, you have to look for the gastric adenocarcinomas. You have to investigate the patient accordingly. Clear? Now here it is a very, very important question. Please tell me the answer. I hope you all can see the poll. Bilal, it is seen in association with metabolic syndrome. And metabolic syndrome includes PCOS. You have insulin resistance, right? And these insulin resistance can cause development of acanthosis nigricans. Even obesity, hyperlipidemias, diabetes mellitus, all of them can cause presence of or development of acanthosis nigricans. Clear? Very nice, Dr. Tariq, Govind, Tushar, Aditya, Harsh, Tramadol, Chinmay, Jiva, Ginni, Lavanya, Shrishti, Ravi, Swat. Very well done, all my dear students. Now it's a very long question. The only thing which I want everybody to note is first that the lesion had spread ascending, so it's a progressive lesion. The another point which I want everyone to notice on examination, you have 5 into 4 centimeter lesion in the dorsum of the hand with nodular lymphangitis. Among the options provided, sporotrichosis is a deep fungal infection which runs through lymphatics, and that is why you see linear lesions. Now, those who have attended my plus class today, Bilal and other students, Ravi, I hope you remember the image which I've shown you in the morning. So you have involvement of the lymphatics, and that is why you develop linear lesions or ascending lesions in a patient of sporotrichosis. Now, can you tell me what will you see when you do histopathology in this patient? Anyone? When you see histopathology, what will you see? Very nice. You will see star-shaped bodies, which is known as asteroid bodies. Star-shaped bodies, which is known as asteroid bodies. Clear? Please give me a thumbs up if you understood this question. Very, very easy and interesting, I guess. Should we go to the next one? Okay, fine. Anyone? Very nice. Rosh, Trumadol, Lalita. Ravi, Jayalakshmi, Sangita, Aruna, Tushar, Sesha, Lavanya, Pallavi, Jiva, Tarik. Very well done, all of you. Please remember the correct answer is option number 3. A 62-year-old male who presented with itchy rash, a 7 kg weight loss, and on examination you can see that there is erythematous plaque all over the body. Along with that, the lymph nodes were involved. When we did a biopsy, we could see neoplastic cells within the epidermis. We could see neoplastic cells within the epidermis. Then what could be these neoplasm? This is a classical case of cutaneous T-cell lymphoma, and you see atypical T lymphocytes, which is known as Sézary cell with classical cribriform nucleus. So somewhat like this, like a brain, cribriform or cerebriform nucleus. Can you tell me why do you see the cribriform nucleus in T lymphocytes of mycosis fungoides or cutaneous T-cell lymphoma? Anyone? Tushar, Faith, Trumadol, Ravi, anyone? Please remember, it tells you that these cells are rapidly progressing. Rapidly progressing. What happens whenever a cell has to divide into two? The first thing which happens is the nucleus divide, and then there is division of the cell bodies. Okay. Now, what happens in cutaneous T-cell lymphoma? There is a stimulus for rapid or quick proliferation of T lymphocyte. So what happens? The nucleus will start to proliferate, but the cell bodies take time, and this rapid proliferation, the nucleus is very similar to cribriform, and that is why it has a cribriform appearance. Understood or not? Anyone? So the reason for the cribriform appearance of the nucleus or cerebriform appearance of the nucleus is rapid stimulus for proliferation. Okay. What is the difference between mycosis fungoides and Sézary syndrome? Please remember, mycosis fungoides is a cutaneous lymphoma. You have deposition of atypical lymphocyte in the skin. But when the T lymphocyte loses its capability or it enters the blood, it becomes leukemic, then it is known as Sézary syndrome. Understood or not? But please remember, Sézary syndrome, it need not be preceded by mycosis fungoides. You can have a de novo development of Sézary syndrome also. And Sézary syndrome is actually known as leukemic variant of cutaneous T-cell lymphoma, where you have atypical T lymphocytes circulating in the body. Understood, Shesha? Clear or not? Okay, fine. Very well done. Very well done. A 6-year-old boy reported with the complaint of frequent painful ulceration of the oral cavity since 3 years. His parent gave a history of skin erosions on the back and arm at the time of birth. Since then, the erosions occurred all over the body and it healed by scar formation. His toe and fingernails are absent. What could be the diagnosis? Very nice. Okay. Now, if you all remember that I always tell you that epidermolysis bullosa, yes, it is very frequently seen cases. Like it is not very rare. We think that it is rare, but you do get to see the cases, like not very frequent, but yes, you do get to see the cases of epidermolysis bullosa. Now, there are three types of mechanobullous disorder. One is EB simplex, then we have EB junctional, and another is EB dystrophic. In EB simplex, can you tell me what is the gene defect? Anyone? What is the gene defect? Or the deficiency of which component? Very nice, Harsh. You have deficiency of keratin 514. In EB junctional, you have deficiency of laminin 5. And EB dystrophic, you have deficiency of collagen 7. So what happens? In EB simplex, the patient usually present in an adult life. They will complain with the complains you that there is frequent erosions on the body, but it is usually seen in the adult life. While EB junctional and EB dystrophic, they are present since birth. The only way to differentiate both of them is scarring is absent in junctional type, while scarring is present in the dystrophic type. Scarring is absent in junctional and it is present in dystrophic type. Clear or not? Please give me a quick thumbs up if you understood this point. Very, very nice. So here they have clearly mentioned that the lesions were healed with scarring. So that is why the answer is option number 3. And here you have deficiency of collagen 7. You have deficiency of collagen 7. Okay, Ji. The next question is on your computer screen. Aruna, in epidermolysis bullosa simplex, you have keratin 514 defect. In junctional, laminin 5, which is the component of lamina lucida. And in dystrophic, collagen 7, which is the component of sublamina densa, is defective. Clear? Very nice, Mr. SL. So this is a very interesting question that Mr. SL was a 35-year-old driver who presented at the emergency unit with a 2-week onset of fever, dysentery, dysuria, and joint pain. The joint pain involves the left wrist, the right ankle, and the ankle joint. We had urethral discharge. So just write the features of arthritis, urethritis. There is no other features, but it is associated with redness of the eyes, conjunctivitis, and this is a classical triad of Reiter's disease, which is seen secondary to chlamydial urethritis, seen very frequently to chlamydial urethritis. Can you tell me what is Reiter's disease? Anyone? R-I-T-T-E-R. Tushar, Ravi, Jiva, very well done. Please remember, Reiter's is staphylococcal scalded skin syndrome. Staphylococcal scalded skin syndrome. Very well done. Very well done. Should I go to the next question? Very nice, Lega, Yogesh, Shrishti, Jiva. Then we have Harshad, Trumadol, Dr. Sana, Aruna, Lavanya, Anonymous, RP, Rosh. Very well done, all of you. Amazing, everyone. Amazing. The correct answer here is option number 1. Now, if you look carefully, can you see these beads on the hair at a regular interval? Yes or no? I hope you all can make these small dotted structures. Yes or no? You want me to zoom a little more? Can you see them now? Here, 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 here. If they are present here as well, they are present here also. And if you look at this part, they are present. So many black swellings or black, what do you say? Like it's like a concretions. Now they are very hard. So much so that when a patient comb the hair, they feel a gritty or a rough sensation. Very nice. Please remember it's a classical case of black piedra, and please remember the causative agent for black piedra is piedra horte. Piedra horte. Okay. Now please remember the Wernicke is the causative agent for white piedra, not the black piedra. Okay. So please remember these are very, very important. They are fungal infection and they have to be treated by antifungal drugs. So RP, if you have this, please go visit a dermatologist. Make sure that they are, these nodules only. They should not be something else. Okay, because you do have a lot of other hair shaft disorders like trichorexis nodosa. They will also present with nodes at a regular interval. So it's not very, very common to get piedra horte or black piedra lesions, but it is more common to have a hair shaft disorder. So I would recommend you to visit a dermatologist nearby, so that if you have any hair shaft disorder, it has to be taken care for. uh, Yes, it can be because of both. It can be because of both, Tushar. Okay. Now, please remember the black piedra is piedra horte. How to differentiate black piedra from white piedra? Anyone can tell me the answer? White piedra is comparatively soft, while black piedra, they are hard to touch. Okay. So that is how you can differentiate between both of them. And yes, obviously, the color is a very important differentiating feature in between both of them. The next question is on your screen. Very nice, Akshat, Dr. Sana. Okay, fine. Now, please remember, in this particular question, they are asking you, first of all, which of the following is false statement? Can you tell me what is the diagnosis here? A 50-year-old female with several soft tissue nodules on the body, including head and neck, multiple hyperpigmented macule. She did not have any systemic problems in the organ. Offspring have this similar lesion in variable frequency. So you have a positive family history, multiple hyperpigmented macules, which could be cafe au lait macule. So you are clear that this is a case of neurofibromatosis type 1. Now, multiple hyperpigmented macules, which are seen in these patients, are here since birth. Very correct. Please remember, cafe au lait macule can present from birth. So it is the first cutaneous presentation of a neurofibromatosis type 1 patient. It is an autosomal dominant condition, and do slit lamp examination to look for we do slit lamp examination to look for iris leash nodule. To look for iris leash nodule, we do a slit lamp examination. Large masses seen in this particular patient. Can you tell me what is this large mass? This is a plexiform neurofibroma. And please remember, plexiform neurofibroma is considered to be a diagnostic criteria. So option number 2 becomes incorrect. Clear or not? Tushar, Tariq, and all my dear students, please remember that it is incorrect. Option number 2. Chalo ji. So let's move to the next question. I hope you all have understood till here. Any more confusions for that question? No. Yes, you're right, Dr. Tariq. It is also known as von Reckling-Hussein's disease. A 70-year-old male presented with a skin lesion on his face. On examination, there is sharply demarcated, darkly pigmented papules with a greasy stuck-on appearance. Which of the following is the most appropriate next step in management? Very nice, Sangeeta, Yogesh, Raj, Ravi, Sam. Can you tell me what is the diagnosis here? Anybody can tell me what is the diagnosis here? It's a very, very classical case of or classical image of seborrheic keratosis. Now, in seborrheic keratosis, you see yellowish, greasy scales which appears as if they are just stuck on the skin surface. When you scratch them, they can easily come out. And please remember, you do not need to treat them. You just need to ask the patient to have a regular, to have a regular follow-up. Can you tell me why we are asking a patient for a regular follow-up in seborrheic keratosis? I told you it is a completely normal condition. Then why we are asking the patient to come again? No, it is not pre-malignant. It is not pre-malignant, neither cancerous. Can you tell me why we are calling it or why we are calling the patient? Please remember, when a patient develops sudden increase in the size or sudden increase in the number of seborrheic keratosis, it indicates that there is an underlying malignancy. Per se, seborrheic keratosis is not malignant. So this is a paraneoplastic condition. Whenever a patient has underlying lung cancer, there is sudden increase in the size and the number, and this is known as lesser prelate sign. This is known as lesser prelate sign. Very, very important, lesser prelate sign. Please give me a quick thumbs up, all my dear students. Tariq, Raj, Aruna, RP, if you understood this point. Okay. So only thing which you have to do is reassurance and ask the patient to visit your clinic frequently. So if there is any sudden change, it can be taken care of at a proper time. Okay, okay. Chalo, let's move to the next question. Are you all ready? A long clinical case question. So please look at the image, read the question. Very well done, all of you. A 2-year-old girl was brought by her mother who reports that the child has a mark that grew in size and bleed spontaneously. Dermatologists examined and have seen that this is hyperchromic brown and the lesion has nest of epithelioid cells, spindle cells with a lot of caminobodies, which are the eosinophilic globules. This is a very, very classical description of Spitz nevus, which is a melanocyte nevus, or it is a melanocytic nevus. Previously, we used to confuse Spitz nevus with malignant melanoma, but please remember in Spitz nevus, you will not see any disorientation of the, or any hyperchromicity of the nucleus that is not seen. You have normal nucleus, and there is presence of a very classical bodies which are known as caminobodies. It's very, very commonly seen in children, and it is completely benign condition. It is not malignant. So please remember, caminobodies seen in Spitz nevus, which is a benign condition, seen very commonly in children. Understood? Any confusion with this? Okay, ji, fine. Let's move to the next question. A 60-year-old female with no past medical history presents with well-defined hyperpigmented plaque in the axilla. Woods lamp examination showed coral red fluorescence, and samples from the macerated interspace were sent to 20% KOH preparation. The KOH was negative for fungal organism, but the tissue culture shows Corynea bacteria species. What is your diagnosis? So it's again a very, very interesting question. Very nice. Coral red color when it is visible. And the Corynea bacteria species, it's a very, very classical case of erythrasma. And the species, as very correctly said by Dr. Tariq, it is Corynea bacteria minutissimum. Can you tell me what is the causative agent of tinea cruris? You have to give me only one name. What is the most common cause of tinea cruris? Please remember, if you have to give only one name, please write Trichophyton rubrum. The most common dermatophytic species causing tinea is rubrum, followed by mentacrophyte. What about Trichomycosis axillaris? Can you tell me what is the causative agent? Trichomycosis axillaris, what is the causative agent? Ravi, you can tell me the answer because we have read it in the morning only. Or I think yesterday we have read. Please remember, it is Corynebacteria minutissimum. Sorry, minutissimum is for the erythrasma. I'm very, very sorry. It is Corynebacteria tenuis. Minutissimum is for erythrasma and tenuis is for Trichomycosis axillaris. Very nice, Sangeeta, Vidyananda. Very well done, all of you. Clear? Okay. Now let's move to the next question. A 47-year-old man with a history of recent subclinical hepatitis C infection presents complaining of a rash, mouth pain for past week. The rash is pruritic and on examination it is present on the wrist, ankle and scalp. You can see shiny, violaceous, sharply demarcated confluent papules containing white lines in the lacy pattern. And on examining the oral cavity, you can see reticulate white appearance. Which of the following is the most likely diagnosis? Lichen planus, dermatitis herpetiformis, leukoplakia, or Kaposi varioliform eruption. Or Kaposi varioliform eruption. Very well done. Please remember, it's a case of lichen planus. All the characteristic descriptions. Hepatitis C, a very common predisposing factor. Itchy lesions, mainly present on the flexures. They are violet color, papules, and what are these white lacy patterns called as? Anyone? What are these white lacy patterns called as? Very nice, Dr. Tariq. They are called as Wickham's stripe. They are called as Wickham's stripe. Okay. Very well done, all my dear students. Tell me the answer of this question. A 30-year-old married female is presented in the Department of Dermatology with constitutional symptoms. There is no previous fever with joint pain, abdominal pain. On examination, you can see multiple tender erythematous plaque with pseudo-vesiculations. I hope you all can see the poll. Histopathology shows mild spongiosis, flattened rete ridges with moderate edema and diffuse inflammatory infiltrate. What will be the diagnosis? What will be the diagnosis? Harshad, Lega, Yogesh, Jiva, Sam, Dr. Cardio, Dr. Sana, RP, Akshat, Raj, Trumadol, Venkatesh, Dr. Priya. Very well done, all of you. This is a very, very classical case of sweet syndrome. What is sweet syndrome? It's a neutrophilic dermatosis where you have infiltration of neutrophils in the skin. Now, what is the feature? They will classically present with fever, followed by multiple erythematous, painful papules and plaque. And there is acute inflammations, and that is why you see pseudo-vesiculations surrounding the plaque. And that is why you see pseudo-vesiculations surrounding the plaque. I hope this is clear. Please give me a thumbs up if you understood. The site is mainly trunk. And can you tell me what is the causative agent for sweet syndrome? Please remember, it is a multifactorial condition, can be seen secondary to infections like streptococcus, can be seen secondary to malignancy, that is acute myeloid leukemias or acute lymphocytic leukemias, malignancy, and it can also be seen secondary to drugs like GCSF or GM-CSF. So please remember, it is a multifactorial condition. Can you tell me what should be the treatment of choice for sweet syndrome? What is the treatment of choice for sweet syndrome? Shubham, Vishnu, Tarik, Vidyananda, Sangeeta. Yes, please remember in all the neutrophilic dermatosis, Depson is a very important drug. But to take care of the acute state, you can even give steroids, oral steroids. Please remember, you can give oral steroids if to take care of the acute infections or acute inflammation. If it is secondary to infection, you can add oral antibiotics also along with oral steroids. Clear? Any confusion in this question? Okay, ji, fine. Let's move to the next question. A 45-year-old female presented with history of insidious onset of peeling of skin, vesiculobulous lesions, oral ulcers which develop over previous 10 years, which occurs over previous 10 days without any acute primordial signs or symptoms. Now, she gave a history of fever on and off and multiple joint pains for 2 days, for which she has taken a drug that is diclofenac and naproxen. So, can you tell me what will be the answer here? What will be the answer in this particular question? Okay. So please remember, this is a classical case of drug rash. This is a classical case of drug rash. And they have clearly mentioned that the patient has oral erosion, so you can easily rule out staphylococcal scarlet skin syndrome and toxic shock syndrome. I hope you all remember that both these are because of staphylococcus, and staphylococcus affect desmoglein 1. And desmoglein 1 is absent in oral cavity, and that is why you never develop oral cavity lesions in both of them. Please give me a thumbs up if this point is clear. Now, how to differentiate between option number 1 and 2? Please remember, in Stevens-Johnson syndrome, you will have a very localized exfoliation. Only less than 10% of the body surface area is involved. But here they are given that the patient developed onset of peeling of skin and vesiculobulous lesions. So it has to be more than 30%. They have not mentioned anything about the location or the site. So assume that it is a generalized case and please mark option number 1, toxic epidermal necrolysis. Clear? I hope this question is clear to all of you. Okay, ji. Amazing, amazing. Let's move to the next question. So very nice, all my dear students. I think everybody have answered this question very, very easily and clearly. So here you have a 70-year-old male who has skin lesions on the neck. And on examination, you can see that they are pedunculated. Pedunculated means they have a peduncle. They are somewhat like this. Which of the following is the most likely diagnosis? Please remember they are skin tags. And can you tell me another name for skin tags? Acrocordons. Please remember they are also known as acrocordons. Okay? What is skin tags also known as acrocordons? Clear? Am I visible? Am I visible to all of you? Yes. So please remember it is acrocordon. Any significance? Yes, definitely. If you develop multiple skin types, always go for serum lipid profile, or always go for the blood sugar levels, because they are very commonly associated with metabolic syndromes. The commonest being hyperlipidemias. Whenever you have increased triglyceride level, the risk of developing skin tags are more. So very significant if you have associated conditions. And even in diabetes patients, you can see a lot of acrocodons in them. Clear? How to treat? It has to be removed. You can either remove it by a simple seizure. You can just cut it, and you can just put a gauze to remove or to stop the blood. If you want to do it bloodless, you can use either electrocautery or you can use radio frequency cautery to have it removed. Clear? Any confusion, Aruna? Any confusion? Okay. It is not necessary that like if anybody, if any one of you is having it, please do not think that you are prone for lipid increase or something like that. Okay, so please don't get scared. Multiple as much as in pick when to advise lipid profile. See, normally if a patient comes, we always advise, because sometimes the congenital hyperlipidemias can also have these type of lesions. So always make a protocol. Yeah, I understood looking at your facial expression, Aruna. So there are many other factors also other than increase in the lipid profile, that is a genetic or a family history. So if your parents are having this, there's increased risk that you can get it yourself. So it's not always directly proportional to the lipid profile. And if you have it in a multiple numbers, Aruna, you can definitely go for a serum lipid profile check done. Okay. Removed under LA, yes, you can remove it under LA. Even without giving LA, it can be removed. And Tohin, like what happens for giving anesthesia, you have to prick the patient, right? You will take a insulin syringe or a 1 ml syringe, and you will give a local anesthesia here. So the pain of the prick is equals to the pain of removal of the skin tags. So even if you do not give local anesthesia, it can be removed very easily. Not very painful. Salicylic acid, you can give salicylic acid, Aditya, but it can cause scarring. Salicylic acid will touch the surrounding normal skin also. Okay. And Dr. Sanjeet, I hope you got your answer. Sanjeet? Okay, ji, amazing. Another question. Please tell me the answer. A 58-year-old female presented with severely itchy rash, initially noted small itchy bump that gradually becomes generalized. She reports that itching is extremely bothersome and often wakes her up at night. Yesterday, she also noticed a lump in the left axilla, and the examination shows diffuse erythroderma with fine scales involving neck, shoulder, back, abdomen, and extremity. There is generalized lymphadenopathy, and a peripheral blood smear shows numerous atypical cells with highly grooved nucleus. The condition of the patient is associated with abnormal proliferation of. Can you tell me what is the diagnosis here? Can you tell me what is the diagnosis here? Yes, it is a classical case of cutaneous T-cell lymphoma or mycosis fungoides. And for these conditions, you have to give, or you have to know that it is a proliferation of T lymphocyte. Can you tell me what type of T lymphocytes are them? CD8, CD4. Yes, they are CD4. And what type of CD4? Helper, cytotoxic, memory. Yes, they are CD4 T helper cells. Okay, they are CD4 T helper cells. CD4 T helper cells. Any confusion? No. Chalo ji, badhiya. Another question is on your computer screen. A 63-year-old patient presented with a lesion on his toe that has doubled in size in the past year. It is not tender and does not bleed, but his wife says that it is getting bigger and darker. The macule is 7 mm in diameter. Which of the following is the diagnosis here? Very nice, Dr. Sana, Govind, Rameshwar, Lega, Yogesh. Please remember, whenever a benign hyperpigmented lesion shows a sudden change in either shape, size, color, please think about malignant melanoma. And what is this criteria known as? What is this criteria known as? This is known as A, B, C, D, E criteria. This is known as A, B, C, D criteria, where A stands for asymmetry, B stands for border, C for color, and D for diameter. So if you have change in any of this, then you have to think about malignant melanoma. It means that the benign condition is getting converted into malignancy. And can you tell me what is the treatment of malignant melanoma? Anyone? How will you treat them? How will you treat a patient of malignant melanoma? Yes, the treatment of choice is excision. You have to give a wide excision depending upon the depth. Very nice. Next question is on your screen. Very nice, Yogesh, Sana, Sangeeta, Anuja, Lega, Harsh, Dr. Tarek, RP, Sam, Toheen, Jayalakshmi, Harshad. A 36-year-old Sri Lankan man has 10-year history of epilepsy, which was well controlled on sodium valproate. Having run out of his regular medication on vacation, he started taking his sister's carbamazepine. He presented to the emergency department 9 days later with a general malaise and widespread blister. On examination, you can see presence of centrally blistered targetoid skin lesions with oral mucosal lesion. Can you tell me what is the diagnosis here? What is the diagnosis here? Okay. So we have a question from RP. How to differentiate between SJS10 and staphylococcal scarlet skin syndrome? Please remember, staphylococcal scarlet skin syndrome, it occurs because of staphylococcus infection. It releases an exfoliative toxin. Which goes and inhibit desmoglein 1. And that is why you develop generalized exfoliation but no mucosal lesion. Clear? Clear, RP? Please give me a thumbs up if you understood till here. Yes? Now, in SJSN10, you see mucosal lesions in both. It is because of drugs in both. But the difference is the skin exfoliation is less than 10%, while in 10 it is more than 30%. So that is how you can differentiate between all three of them. Understood, RP? Please give me a thumbs up or write yes. And here, what is the diagnosis? The diagnosis here is again toxic epidermal necrolysis or a severe drug reaction. Can you tell me which is the culprit drug? The culprit drug is carbamazepine, and always remember, before giving carbamazepine, you have to go for HLA-B1502, because in Asians, if you have the presence of this HLA, there's a high risk of developing toxic epidermal necrolysis or severe drug rash secondary to carbamazepine. Can you tell me what does B5701 indicate? HLA B5701, it is related to abacavir induced drug rash. What about HLA CW6? HLA CW6, anyone? It is for psoriasis. And what about B27? The CW6 is for guttate and B27 is for psoriatic arthritis. Yes, you can even see it in other arthritis as well. You can also see it in other arthritis, but for dermatological point of view, you will have it in psoriatic arthritis cases. Clear? Please give me a thumbs up if you understood this. Okay, ji. A 24-year-old female with a 10-year history of atopic dermatitis. She was admitted to emergency with her fever, malaise, lymphadenopathy, and sudden vesicular eruptions. Physical examination reveals vesicles, pustules, and on doing microscopy, you can see multinucleated giant cell. What is your diagnosis? What is your diagnosis? What is your diagnosis? Please remember, this is a case of eczema herpeticum, also known as Kaposi varioliform eruption. I request all my students who are not able to answer these questions. I teach everything in detail in my plus classes. So please subscribe to Unacademy using the referral code Chesta10. These are very, very important questions and you can highly expect these questions in your upcoming INI-CET exam. So please be prepared for the toughest so that you can answer all the questions very easily. Okay. Now what happens in a patient with atopic dermatitis, you have defective barrier function. And when you have defective barrier function, there is increased entry of pathogen at the site of eczema. Here also, because of a background of atopic dermatitis, you have generalized herpes simplex infection, which is known as Kaposi varioliform eruption or eczema herpeticum. Clear, all of you? Please give me a quick thumbs up if you understood. Very well done. And moving to the next question. Please do take an Unacademy subscription. You can take a 6-month subscription for NEET PG 2022. That will be sufficient. And if you want to prepare for this year exam, please take a 3-month subscription for FMG. I request all of you to please, if you are thinking, do not waste time. Can you tell me what is the diagnosis here? What is the diagnosis? The characteristic example is post-Kala Azar dermal leishmaniasis. Post-Kala Azar dermal leishmaniasis is the characteristic answer. Clear? Rameshwar, Vidyananda, all of you. So post-Kala Azar dermal leishmaniasis is actually seen 2 to 3 years after a patient recovers from Kala Azar. And here you can see either hypopigmented lesions or multiple soft non-ulcerated subcutaneous nodules. In both these cases, the investigation of choice is smear for Giemsa stain. And can you tell me what you see when you do a Giemsa stain? You will see presence of a classical bodies, which is known as LD bodies, the amastigote forms of Leishmania donovani, known as LD bodies. Clear, all of you? So the correct answer for this question is option number 2. And with this, we are done with the today's session. Everybody will give me a quick thumbs up if you like the today's class. It's my humble request to everyone to please subscribe to Unacademy. Please use the code here. You have to use my code Chesta10 and get yourself enrolled. Please get an Unacademy subscription. I think the smaller subscription would be enough. 3-month and 6-month would be enough. But if you're targeting for 2023 exams or 22, I would recommend a 1-year subscription of Iconic so that you can get the printed notes as well. So bye-bye all of you. Take care and good night. We'll meet again tomorrow at 10 a.m. on Plus Class. Bye-bye. Take care and good day.